بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. أما بعد، سعادة المدير العام التنفيذي، سعادة المدراء التنفيذيين والتنفيذيين المشاركين ومدراء الإدارات، منسوبي مدينة الملك عبدالله الطبية، ضيوفنا الكرام، يسعدنا أن نحييكم ونرحب بكم، فبوجودكم يزهو لقاؤنا الكريم. ومع لمسات الإبداع، اليوم لنا موعد لقاء في ختام برنامجنا، البرنامج الصيفي للبحث العلمي لمدينة الملك عبدالله الطبية بالعاصمة المقدسة، الذي بدأ من تاريخ 7 ذو القعدة 1441 هجرية إلى 2 ذو الحجة لعام 1441 هجرية، ولمدة 4 أسابيع انقضت بكل ما فيها من جهود ومثابرة وأفكار. ساهم فيها ما يقارب من 82 مشاركاً من تخصصات طبية وصحية متعددة، أثمرت في نتاج 14 بحثاً علمياً، والتي ستكون لنا جولة معهم اليوم في عروضهم التقديمية، سائلين المولى لهم كل التوفيق والسداد. أما الآن مع تلاوة عطرة من الأستاذ إسماعيل البلوشي، فليتفضل مشكورا.
الرجيم. بسم الله الرحمن الرحيم. إن هذا القرآن يهدي للتي هي أقوم ويبشر المؤمنين الذين يعملون الصالحات أن لهم أجرا كبيرا، وأن الذين لا يؤمنون بالآخرة أعتدنا لهم عذابا أليما. ويدعو الإنسان بالشر دعاءه بالخير، وكان الإنسان عجولا. وجعلنا الليل والنهار آيتين فمحونا آية الليل وجعلنا آية النهار مبصرة لتبتغوا فضلا من ربكم ولتعلموا عدد السنين والحساب، وكل شيء فصلناه تفصيلا. وكل إنسان ألزمناه طائره في عنقه، ونخرج له يوم القيامة كتابا يلقاه منشورا. اقرأ كتابك كفى بنفسك اليوم عليك حسيبا. صدق الله العظيم.
صدق الله العظيم. أما الآن مع كلمة المدير التنفيذي للأبحاث والابتكار الدكتور خالد سلمان، فليتفضل مشكورا.
السلام عليكم ورحمة الله وبركاته. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه ومن والاه، وبعد. سعادة المدير العام التنفيذي للتجمع الصحي بمكة المكرمة والمدير العام التنفيذي لمدينة الملك عبد الله الطبية الدكتور دلشاد بن علي عباس، أصحاب السعادة المدراء التنفيذيين والمحكمين والمشرفين، ضيوفنا الكرام، زملائي الأفاضل، أبناء الطلبة والطالبات، السلام عليكم ورحمة الله وبركاته. قال تعالى في محكم التنزيل: وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون. فالأبحاث رؤية قيادة وسياسة وطن، تحققها منشآت وجامعات، ويشرف عليها باحثون خبراء وأطباء علماء، ويشعل فتيلها نخبة من الطلبة والطالبات. وفي مثل هذا الموسم من كل عام تزخر مدينتنا الطبية بثلة من هؤلاء النجباء، فيملؤون أركانها وينيرون أقسامها ويتزاحمون في أروقتها بأنشطة بحثية عدة لينهلوا من عذب مواردها، يتسابقون في الخيرات تحقيقاً لقوله تعالى: فاستبقوا الخيرات. ولكن هذا العام تغيرت فيه الموازين، ومرت بلادنا الغالية والعالم بأسره بظروف استثنائية بسبب جائحة كورونا، مما أدى إلى الإغلاق العام وتوقف كثيراً من الأنشطة التعليمية والاجتماعية. إلا إن همة القائمين على برنامج الأبحاث الصيفي بهذا الصرح المعطاء جعلتهم يبادرون بالتعايش مع الجائحة والمضي قدماً في إقامة البرنامج افتراضياً عبر الشبكة العنكبوتية. وبالفعل فقد بدأ التخطيط لذلك، ونحن ما زلنا في الإغلاق العام تحت شعار كلنا مسؤول. وقد كان لهذا القرار متنفس عظيم لأبنائنا الطلبة والطالبات، فما أن أعلن عن البرنامج إلا وتسارع المهتمون بالتسجيل، حتى بلغ عدد المتقدمين لهذا العام أكثر من 2000 طالب وطالبة. ولكن جودة البرنامج تحتم علينا الاقتصار على ما لا يزيد عن 85 مشارك للخروج بالفائدة المرجوة من هذا البرنامج. وها أنا اليوم أقف أمامكم لأقدم كل الشكر والتقدير للقائمين على هذا البرنامج من منسوبي الإدارة التنفيذية للأبحاث والابتكار، وأخص بالذكر سعادة الدكتورة سهى المرسي لمبادرتها بفكرة عقد البرنامج افتراضياً وتقديمها جل محاضراته النظرية عن بعد، وكذلك لسعادة الأستاذ ماهر الحازمي لإشرافه المباشر على البرنامج بكل تفاصيله وإلى هذه اللحظة. وكل تلك المبادرات والترتيبات بما فيها من مخاطر مدروسة من جميع القائمين على البرنامج، حتى لا نضيع فرصة هذا الصيف على أبنائنا الطلبة والطالبات من مختلف دون ما فائدة أو إنجاز، حتى لا نضيع فرصة هذا الصيف على أبنائنا الطلبة والطالبات دون ما فائدة أو إنجاز. كما أقدم اعتزازي بالطلبة والطالبات المشاركين من مختلف أطيافهم ومرجعياتهم الذين آثروا العمل والاجتهاد رغم تحديات الأحداث ليتحفوا مسامعكم بأنفع الأبحاث بالانخراط في هذا البرنامج البحثي في دورته الثامنة على التوالي والأول افتراضياً. ومن خلف هذه الاستدامة والإبداع هنالك إدارات وأقسام وأناس كثر من وراء الستار لا يعلمهم كثير من الحضور، لهم أدوار شتى من إشراف وتعليم وتوجيهات وتشجيع ودعم وتسهيلات وتقنية وإدارة للمعلومات وإعلام ونشر للمخرجات وتنظيم وتنسيق وترتيبات، فلله در الجميع والشكر في حقهم بديع. إن قلت شكرا فشكري لن يوفيكم، حقا سعيتم فكان السعي مشكورا. إن جف حبري عن التعبير يكتبكم قلب به صفاء الحب تعبيرا. وعلى رأسهم سعادة المدير العام التنفيذي وجميع الإدارات التنفيذية والإدارات والأقسام والأشخاص الفاعلين وبدون استثناء. وبشكر خاص لضيوفنا أصحاب السعادة المحكمين الذين تكرموا علينا بتلبية دعوتنا، فنجزل لهم الثناء والامتنان والشكر والعرفان. وفي مثل هذا الحفل من السنوات الماضية كانت هذه القاعة تعج بحضور المئات من كل حدب وصوب للاستمتاع بمشاهدة ملخصات الأبحاث الطلابية التي تتزايد فيها منافسة المجموعات وتتحسن فيها جودة الأبحاث عاماً بعد عام. ولكننا هذا العام وتحت شعار نعود بحذر وحسب تعليمات الجهات المختصة فلن تجدوا حضوراً لأكثر من 50 شخصاً في هذه القاعة الكبرى. وفي المقابل سوف يستمتع آلاف المشاهدين عن طريق النقل المباشر لكل أصقاع المعمورة بسماع 14 بحثاً نتجت من مجهود 82 طالب وطالبة من مختلف كليات الطب والصيدلة والعلوم الطبية، تم ترشيحهم للالتحاق ببرنامج هذا العام من بين آلاف المتقدمين. ولقد أحسن الشاعر عندما قال: ولرب نازلة يضيق بها الفتى ذرعا وعند الله منها المخرج، ضاقت فلما استحكمت حلقاتها فرجت وكنت أظنها لا تفرج. وقد تركزت جل أبحاث برنامج هذا العام عن جائحة كورونا توافقاً مع حاجة الزمان والمكان وخدمة للوطن والإنسان. وآخر دعوانا أن الحمد لله رب العالمين، والصلاة والسلام على خاتم الأنبياء والمرسلين.
نستعرض الآن آلية تقييم الأبحاث العلمية المشاركة بالبرنامج الصيفي للبحث العلمي لمدينة الملك عبد الله الطبية بالعاصمة المقدسة. سيقوم أعضاء لجنة التحكيم وحضورنا الكريم كذلك بتقييم الأبحاث المشاركة معنا. الرجاء اتباع التعليمات الآتية لتقييم الأبحاث العلمية. أولاً، الرجاء ربط أجهزتكم المحمولة بالشبكة اللاسلكية KR Capital E Small SP Capital 2020. شغل الشاشة. طيب شغل الشاشة. ثانياً، استخدام الباركود للوصول للبرنامج. ثالثاً، استخدام كود التصويت الخاص بك لتقييم جميع الأبحاث المشاركة بالمسابقة، مع ملاحظة أنه لا يمكنك التصويت للبحث أكثر من مرة. ننوه أن جميع المعلومات المذكورة موجودة على مقاعدكم. نرحب بلجنة تحكيم البرنامج الصيفي للبحث العلمي، وهم الأستاذة أشواق عبد الغني قواص أخصائي أول وبائيات، الدكتورة أحلام عمر المسعري طبيب استشاري سرطان الدم وقسم زراعة العظام، الدكتور زياد عزة الجندي طبيب أخصائي مخ وأعصاب. نبدأ الآن في العروض التقديمية لفرق العمل مع المشروع الأول بعنوان The Prevalence and Prognosis of Neurological Manifestation Among COVID-19 Patients Admitted to King Abdullah Medical City Retrospective Cohort Study. بعد دقيقتين من الآن.
Hello. Good morning, everyone. On behalf of my team, I would like to present our project, which is the prevalence of the neurological manifestations among COVID-19 patients admitted to King Abdullah Medical City. As we all know, the COVID-19 virus is the main target of the respiratory system. But with increasing evidence, it shows that increasing evidence shows that it's not only the respiratory tract is the main target, but also the nervous system, and it can invade it and cause damage to the neurological functions. There are many pathways of that cause neurological manifestations, including the hematogenous pathway, so the virus can invade the blood-brain barrier and travel to the brain. Second, there is an angiotensin-converting enzyme receptor, which has a strong binding affinity to this virus. So it's considered the main entry point to the coronavirus to the brain. Our primary objective is to determine the prevalence of neurological manifestations among COVID-19 patients. We have two secondary objectives, which is to report the most common neurological manifestations and to know the prognosis of each patient based on whether the patient is disabled, still admitted in the hospital, or died. We select all COVID-19 patients who is admitted to the KMC, as we mentioned before, and we search for patients who seek consultation from the neurological department. We include all positive COVID-19 patients from December 2019 to June 2020, and the age is 18 and above. And we exclude all patients who is diagnosed previously with neurological manifestation or disease or any malignancy. Also, we exclude any pregnant female, and the age is under 18. The data was collected in a retrospective approach through the KMC record independently. We use a specific data collection form, which include the comorbidities, the demographics of the patient, family history, laboratory finding, and the imaging. For the total patients we find is 300 with positive COVID-19, 18 of them with a prevalence of 6% had neurological manifestations. 18 patients of them with 3.6% had neurological consultations and fitting our inclusion criteria. So the demographic characteristics of our 11 patients, they are the range of age between 70 to 79, and 6 male patients and 5 female, and all of them had comorbidities, including hypertension, diabetes, and smoking. The most common neurological manifestation is the impaired level of consciousness with a prevalence of 81.1%, followed by seizure and weakness, followed by syncope and numbness. The imaging study, 9 patients had a CT brain, and 4 patients had MRI brain, with all of them have abnormal results, including ischemic brain insult and leukoencephalopathy, which may or may not related to the COVID-19 infection. 45.5% of patients died, 27.3% still admitted in the hospital, 18% recovered. Compared to our results to the previous literature in similar studies around the world, the Chinese study of 214 patients demonstrated that the prevalence of neurological manifestation is 36.4%. The same study shows that acute stroke is a prevalence of 5% and the impairment of consciousness is 19%. Another study also in China demonstrated that the prevalence of headache is 30% in a total number of patients, 62, and the final study is in Italy demonstrated that the prevalence of chemosensory dysfunction, which include impairment of the taste and taste sensation, is 19%. So the literature is support our finding. The neurological manifestations associated with poor prognosis, worsening of the clinical outcome, and sudden death. Back to our study result, our conclusion is that 6% of patients had neurological manifestations. We enrolled 11 patients with 3.6% consulted the neurological department. The most common neurological symptoms was impaired level of consciousness, followed by seizure and weakness. The death was the outcome of 45.5%, and 18.2% of patients experienced a full recovery. We face a limitation because neurological manifestation and consultation was only requested for a major symptoms, such as impaired level of consciousness or seizure or weakness, but not for the common mild symptoms such as headache and anosmia. So several patients were not included in our study. Neurological manifestations cannot be ignored in COVID-19 patients. It's associated with poor outcome, as we mentioned. The involvement of the nervous system is associated with the development of neurodegenerative diseases, such as Parkinson's disease or multiple sclerosis. Therefore, the awareness of the neuroinvasive nature of this virus may lead us to the development of an approach so we can detect early the disease and treatment and prevention of the possible common neurological manifestations. Okay. Thank you all.
ابتدأ التصويت لمدة 30 ثانية. انتهى التصويت. أما الآن مع المشروع الثاني بعنوان Impact of BMI in KAMC patient with heart failure.
Assalamu alaikum wa rahmatullahi wa barakatuh. First, I would like to thank you all for giving me the chance to present here today. My name is Rinan Abdelwahab Al-Abbasi, and I am member team in Project 14 under supervision of Dr. Ghada Shalabi. So, as you see here, our title is The Impact of BMI in KMC Patient with Heart Failure. I will start by giving you some important background information. Heart failure is a growing public and health concern in developing countries, including Saudi Arabia, and it has an estimated prevalence of more than 37.7 million individuals globally. So why BMI? Obesity is a known risk factor of heart failure. The majority of studies have recommended that the overweight and mild to moderate obese patients have better prognosis and lower risk of complication than normal weight patients. And this has been termed as obesity paradox. So here in KMC, we have large number of patients with heart failure. So we thought, why not we assess the impact of BMI on clinical presentation, management, and outcome of heart failure patients, and this is our primary objective. So our study design is retrospective analytical cohort study. This is our method. We take the information from electronic file. We include all patients diagnosed with heart failure between 2019 and 2020, and we exclude any patient with valvular heart disease and any patient with insufficient data. So we compare two groups, obese and non-obese, by using t-test and chi-square test for continuous and categorical data, and we did also a regression analysis. So the two groups compared regarding the baseline demographic, the investigation, outcome, risk factor, and we did regression analysis to see the independent factor for in-hospital mortality, and we did also a correlation. So our total sample size was 410 patients. 37 of them were obese, and 63 of them were non-obese. So we will start by demographic data. Saudi here represent 81% of obese group and 70% of non-obese group. Also the belligerents represent 5% of obese group and 40% from non-obese group. All other demographic data like age and gender show no significant difference. So also for the risk factor, no significant difference were found regarding all the risk factor here. We found a very interesting result regarding the etiology and presentation. We found that non-obese patients have a higher prevalence of ischemic cardiomyopathy, and obese patients have a higher prevalence of dilated cardiomyopathy. Also, obese patients presented with congestive heart failure, and non-obese patients presented more with ischemic cardiomyopathy, ischemia. So for the lab, only glucose and troponin was high in non-obese patients, and that's true because we say that non-obese patients came with ischemic cardiomyopathy, so that explains why peak troponin is high in this group. Also, the hemoglobin discharge on discharge was higher in obese patients. For the echocardiograph, left ventricular ejection fraction tend to be higher in obese, and right ventricular function more affected in obese also, and it's maybe because of obesity-related pulmonary disease. Also, for the coronary angiograph, 3-vessel disease and PCI was higher in non-obese patients. For the management, using Entresto was higher in obese group, using ACE, ARBs, and clopidogrel was higher in non-obese group. Also, obese group were more needed for device therapy in form of ICD and CRTD. All other medication and labs and coronary angio finding show no significant difference between obese and non-obese. Also, there is no significant difference were found regarding all the outcome. There was a statistically significant positive correlation between BMI and length of hospital stay, and we know all that length of hospital stay is affect the hospital burden. So, type of cardiomyopathy was the only independent predictor for in-hospital mortality, and chronic kidney disease tend to be independent, and BMI is, we found that BMI is not an independent predictor for in-hospital mortality. So we conclude that obesity prolonged in-hospital stay in heart failure patient. Type of cardiomyopathy was the only significant independent predictor of in-hospital mortality, and BMI is not an independent predictor of in-hospital mortality. Also, the obese patient had less prevalence of multi-vessel disease. Most of the obese patients presented with heart failure symptoms rather than ischemia or arrhythmia. Also, no significant difference were found between both groups regarding in-hospital complication and risk factor on unadjusted analysis. However, in-hospital mortality was lower in obese patients, but not different statistically on unadjusted analysis. So, up to our knowledge, we are the first study to explore the impact of BMI in heart failure patients. We faced some challenge, like we conduct the research during COVID-19, large number of cases compared to number of group members who participate in data collection. And we recommend conducting more research with large sample size to further explore the mortality and morbidity. And we should focus on the obesity management, as it's a great burden on the health system and financial resource. Our goal is to publish our research in well-known journal, and we hope to conduct other research related to heart failure. Many thanks to CRISP member teams and Dr. Sohan Mursi. Thank you.
بدأ التصويت. انتهى التصويت. والآن مع العرض الثالث لمشروع عنوانه Cardiomyopathy Management in a Tertiary Care Center Clinical Component and Venous of Care KAMC مكة سعودي عربية.
Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Imad Babtain. I'm a fifth year medical student. I would like to thank the Research Center for providing me this opportunity to represent our group of Project One, supervised by Dr. Shireen Khalid. Our main topic is talking about cardiomyopathy management in a tertiary care center, clinical components, and venues of care. Okay. First of all, cardiomyopathies are a group of disorders affecting the heart muscle. They can be classified into three types: ischemic cardiomyopathy, dilated cardiomyopathy, and hypertrophic cardiomyopathy. At 2010, the WHO reported that ischemic heart disease, which is a type of cardiomyopathy, was the largest single cause of death, accounting for about 26% of the overall deaths globally. Moreover, in Saudi Arabia, the Ministry of Health stated that cardiovascular diseases, including cardiomyopathy, accounted for about 42% of the overall death at 2010. With the introduction of new treatment options, cardiomyopathy management has significantly improved. We have two types of treatment options: the standard treatment and the advanced treatment. The advanced treatment is composed of psychobacterial valsartan combination and the device therapy, including revascularization device and the cardioverter defibrillator device. Our question is, what is the prevalence, clinical manifestations, and lines of management for patients who are admitted at KMC with heart failure symptoms, and why exactly we chose KMC? So our main objective is to identify the prevalence, clinical manifestation, and management of different types of cardiomyopathy at King Abdullah Medical City. And our secondary objective is to differentiate between dilated and ischemic cardiomyopathy regarding the clinical manifestations, identify the percentage of patients with ICM and DCM who needed the advanced therapy. This study is the first study by its kind in Saudi Arabia. Although cardiomyopathy management, cardiomyopathies has been studied intensively in different parts of the world, but such results may not be applied to our community pertaining to cultural, environmental, and individual differences. We as a research team want to nourish this field as we think it might be helpful for the effective management of cardiomyopathy patients. It will provide the Saudi heart community more insightful view of the prevalence, the severity, and how the new approaches are being effectively used and allocated to the candidate patients. The study was conducted at King Abdullah Medical City as it is the only tertiary care center providing advanced support for the cardiac patients. It is a representative sample for the whole Western region. We included all patients admitted with heart failure symptoms at KMC from 2019 till 2020. There are about 398 patients. It is a retrospective cohort study. We excluded the patients who are out of scope of our service and who admitted before 2019. Track care system and Accelera system were used for collecting the data. SBSS was used for statistical analysis, and chi-square test was used for categorical variables. T-test was used for numerical data. Our results. As you can see here in the pie chart, ischemic cardiomyopathy is more prevalent than dilated cardiomyopathy, and rare cases of hypertrophic cardiomyopathy were reported. And in the bar chart, you can see that dilated cardiomyopathy patients presented with more severe symptoms compared to ischemic patients. In this table, we show that in comparison between dilated and ischemic cardiomyopathy patients, dilated cardiomyopathy patients were younger at age, more obese, with less frequent cardiovascular risk factors, including diabetes, hypertension, and chronic kidney disease. Moreover, the echo findings showed that the left ventricular dysfunction was more significant in dilated cardiomyopathy patients compared to ischemic cardiomyopathy patients. In terms of the outcome data, we found that dilated cardiomyopathy patients had less mortality rates compared to ischemic cardiomyopathy patients. And in terms of treatment options, dilated cardiomyopathy patients were in higher need for the standard treatment. Furthermore, they were more candidate to the advanced therapy, including sacubitril valsartan, with better compliance and higher titration. And also they were more candidate to the device therapy compared to ischemic patients. And regarding the ischemic cardiomyopathy management strategies, revascularization therapy was the most common strategy used at KMC, followed by medical treatment and then coronary artery bypass surgery. In conclusion, there are disparities in the prevalence, demographics, clinical characteristics, and outcomes between dilated and ischemic cardiomyopathy. And an interesting result is that while dilated cardiomyopathy patients were younger at age, with less frequent cardiovascular risk factors, they presented with more severe symptoms, and they were more candidate to the advanced heart failure treatment. However, they had less mortality rates compared to ischemic patients, and most importantly, dilated cardiomyopathy patients responded better to the advanced heart failure treatment. Our recommendation for the policymakers is that they should do comprehensive, proper healthcare coverage, including increase in awareness and implementation of advanced heart failure management revascularization strategies available in all tertiary care centers all over the kingdom. Our challenges: large number of patients had to be collected within a short period of time. And with the pandemic situation, the access to the hospital system was more limited. Long-term follow-ups were non-applicable due to the nature of tertiary care center. This is our journey that will end, inshallah, with publication. And special thanks to all those who helped us and motivated us, provided us with all what we needed to conduct our research. Thank you, Dr. Suhail Morsi, Mr. Maher Al-Hazmi, Mr. Ulum, and thank you all for your valuable attention. This is our abstract. You can scan it and have a look at it. Thank you.
ابتدأ التصويت. التصويت. أما الآن مع العرض التقديمي الرابع بعنوان Retrospective Analysis of Characteristics, Indications and Outcomes of ERCP in a Tertiary Referral Center of Saudi Arabia.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. My name is Faisal Bai'i. I'm a representative of Project 5. It's my pleasure today to present our project presentation. This is the outline. We will go through it. Firstly, what is the ERCP? ERCP is an abbreviation of endoscopic retrograde cholangiopancreatography, which is an advanced endoscopic procedure that has an essential tool in diagnosis and treatment of biliary and pancreatic system. Currently, it is considered a procedure of choice in many pancreatobiliary diseases. There is many indications and complications of ERCP. That is cholelithiasis and biliary stricture, biliary leak, and complication like the most common is bleeding, perforation, and pancreatitis. In Saudi Arabia, there is limited data about different indications and outcomes of ERCP. Therefore, our study is aiming to report the indications and outcomes of ERCP in King Abdullah Medical City in Saudi Arabia. Our main objectives is to evaluate the common indications and outcomes of patients underwent ERCP in King Abdullah Medical City. We also aim to identify the various adverse events related to ERCP. Our study is an observational cross-sectional study conducted in King Abdullah Medical City. We include all patients above 18 years old underwent to ERCP. We collect until now 66 patients. We aim to get large number, inshallah. Regarding to result, the female patient was the most has the highest percentage. The mean age in our patient is 55. The most common indication we found the abnormal imaging in MRCP or ultrasound or CT. We also find the obstructive jaundice has the second most indications. Also, the abnormal liver function has the most indication. Here, the common finding for RCP, we find something interesting. The dilated status in common bile duct was the most obvious status, while the other biliary system duct, the normal status was the most obvious status. Here is the complication. The complication has a low incidence, alhamdulillah, but the most common complication could be happen is bleeding in first, and perforation in second, and pancreatitis in third. In conclusion, ERCP has shown an importance as a therapeutic and diagnostic procedure. The safety for the procedure has been emphasized by low incidence of the complication. This is our reference, and thank you for your time.
انتهى التصويت. ابتدى. انتهى التصويت. أما الآن مع العرض التقديمي الخامس بعنوان The Impact of COVID-19 The impact of COVID-19 in hospital prognosis among cardiac patients in KMC.
Assalamu alaikum everyone. My name is Sajal Hazmi. I represent my team Project 2 with a study titled The Impact of COVID-19 on the In-Hospital Prognosis Among Cardiac Patients at KMC. I would like to start by expressing our gratitude to everyone responsible for this program for their hard work and effort to provide us with an experience that we could empathize from. Okay, moving on. We'll start by explaining the mechanism of action of the virus and its relation to the coronary heart diseases. SARS-CoV-2 attacks the host cell by binding to the angiotensin converting enzyme receptors, which are primarily expressed on the heart, intestine, kidney, and lungs. Therefore, it can reach to the patient's cardiomyocyte and infect it. It was found in different researchers that this mechanism causes a development of myocardial injury or organ dysfunction, which can lead to poor prognosis, along with an increase in the level of troponin of such patients. Therefore, we intend to assess these findings along with any new findings. Multiple conducted research during the period of 2019 and 2020 indicated that cardiovascular patients were more susceptible to develop myocardial injury and or organ dysfunction, as mentioned before. They also had a higher rate of mortality, thromboembolic events, and septic shock. Therefore, we decided to ask the question, what is the impact of COVID-19 on the in-hospital prognosis among cardiac patients? We primarily aim to assess the impact of COVID-19 on the in-hospital prognosis and complication, including mortality. We also aim to evaluate single or multi-organ dysfunction along with the probability of troponin to predict patients' prognosis. Moving on to our methodology, we first started by choosing our study design, which is an observational retrospective cohort study. Moving on, we submitted our protocol and waited for the IRB approval. We then collected our data by reviewing patients' electronic files and using electronic data collection forms such as Google Forms and Excel sheets. Our time period started from March to July 2020, including all patients admitted. Our outcome were assessed as following: SPSS for statistical analysis, chi-square for categorical variables, and t-test with a p-value of less than 5% for continuous data. Our study population included all cardiac patients admitted from March to July 2020, except patients who were less than 18 years old and patients with missing data. However, due to limited time, we started with STEMI cases mostly. Google Forms were used for primary data collection. Then we exported the data on Excel sheet for further confirmation before analysis. We classified our patients into two groups, high-risk patients and low-risk patients, according to Wiqaya COVID-19 classification form. We had a total of 86 patients, 49 of which are low-risk group, 37 of which are high-risk group, and a total of 5 patients who were COVID-19 positive. Our patients' demographic data were as following: 86% of the patients were male. The average mean value of their age was 55.47. Most of them were Saudis. 81 of the patients were STEMI cases. Moving on to our results. As for the lab results, we had no significant change except for the triglyceride and the length of stay between the high-scored and the low-scored groups. Moving on, we compared the high-risk group, comparing the COVID-19 negative and the COVID-19 positive for their comorbidities. We found that most of the patients were diabetic patients. However, there was no significant relation between diabetes and COVID-19 virus. Afterwards, we compared the vital signs of each group for COVID-19 positive and negative also. There was also no significant change except for a tendency during admission of COVID-19 patients who had a higher temperature than COVID-19 negative patients. Moving on, for the in-hospital complication between the COVID-19 negative and COVID-19 positive, there was no significant difference in all complications. Lastly, we compared the length of stay between COVID-19 positive, negative, and the low-risk patients, and we found that the length of stay for COVID-19 positive was doubled compared to the other two groups. We concluded from our study that in patients presented with STEMI during the pandemic of COVID-19, there was no significant change on the patient outcome or the in-hospital prognosis. However, the length of stay was almost double. Our study was limited by the fact that it was a single-center study and also a retrospective chart review study, and the fact that we had to start with STEMI cases due to limited time. We recommend this study to be considered a multi-center study and to consider registry in KSA, and also to expand it to consider all admitted patients. We plan to expand our study period to include the whole duration of the pandemic, and we also plan to continue our study and publish paper, inshallah. Thank you all for listening.
ابتدأ التصويت. انتهى التصويت. أما الآن مع العرض التقديم السادس بعنوان Real World Experience of Biologics in Use in Inflammatory Bowel Disease Patients in Mecca City of Kingdom of Saudi Arabia, a retrospective cohort study.
So, my name is Hisham Mohammed Bakri, and I am presenter of this project. Our supervised by Dr. Karim Sharif. And this is the outline of our project. In the beginning, I will define what is the IBD. IBD, or inflammatory bowel disease, is defined as a chronic inflammation affect intestine, a result from host microbial interaction. There is two major types of IBD. It causes high burden on patients, and the incidence rate of IBD is increasingly, especially in young people. Biologics, now it is mainstay therapy for IBD, for moderate to severe IBD cases. It is genetically engineered medicine, can target specific certain molecules in the body. It costs high, but effectiveness, it has great effectiveness and cost high. And have many side effects. The rationale of this study, there's a paucity of data regarding using a biologics in inflammatory bowel disease in Saudi Arabia. Biologics increasingly being used as a treatment in IBD, and there is no currently head-to-head phase 3 clinical trials of biologics in Crohn's disease. This study aimed to utilize real-world data collected from tertiary hospital database in Makkah City to assess the clinical outcomes of using biologics in IBD patients. Our primary objective to assess the clinical response of biological treatment in IBD patients. Secondary objectives to assess the clinical remission in IBD patients, to compare effectiveness of various biologics, to assess the safety of biologics, to evaluate the pattern of biologics used in IBD patients. We include all confirmed diagnosis of IBD and have at least one follow-up review, and exclude any patient with incomplete documentation. This study is a retrospective cohort study. We collected the data through IBD registry at KMC, TrackCare, Medical Plus, and patient files. IBD registry is a unique system at KMC, created recently as a database for IBD patients at KMC. Okay. Due to limitation of time and during last week until now, we just collected 53 data from patient, from Crohn's disease patient, and this is their demographic. Continuation of same table. This graph shows us location of disease in Crohn's patient. This graph shows us the lines of therapy used in Crohn's disease. I would highlight there is a 41 patient in biologics treatment. Harvey Bradshaw is demonstrate the effect. Demonstrate activity of Crohn's disease. We can see most of patients after using biologic in remission state, unless in activity state. Another method to assess the activity of Crohn's disease are lab results. You can see there is a significant improvement in the lab results, but in calprotectin, not significant, because our our sample small. In conclusion, the result of Harvey-Bradshaw index shows an improvement after use biologic. The biologic also shows a positive significant effect on the lab result. The main limitation was the sample size. Recommend the further studies to conduct. This area of field can show significant results, especially with bigger sample size. Okay, many thanks for CRESP member, and special thanks for Mr. Maher Al-Hazmi and Ilham Bogus for who have been a great assist for this project. Okay, thank you.
ابتدأ التصويت. التصويت. أما الآن مع العرض التقديمي السابع بعنوان The Clinical Outcome of COVID-19 Patients Using Different Treatment at King Abdullah Medical City Retrospective Study.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'm Lujay Maghribi. Today, inshallah, I will present our topic, which is the clinical presentation of COVID-19 patients using different treatment protocols at King Abdullah Medical City. First, at July, the number of cases were increasing up to 10 million per around the world. And until now, there is no approved or registered medication for this coronavirus. The WHO recommendation is to manage the patients according to each patient's need. For example, the mild patients were used the antipyretic and painkiller, and for the severe and moderate cases were followed the following treatments. We have here the hydrocortisone, which have been continued and discontinued throughout this period. Hydrocortisone have been discontinued because the improbable clinical outcome of these in COVID-19 patients, also because the adverse effect associated with cardiac patients. The antiviral, which including the lopinavir, ritonavir, which has been used in COVID-19 patients at the beginning of the epidemic, and since they have also been discontinued, because it doesn't show any efficacy of COVID-19 patients and the improper pharmacodynamic of this drug. We have also the ribavirin, which can be combined with lopinavir and ritonavir in COVID-19 patients, in addition to third drug, which is the interferon, to form the triple antiviral therapy to treat the severe cases patients. The dexamethasone, which is the corticosteroid, have been used in patients with COVID-19 under oxygen therapy, and the antibiotic were used in co-infected patients. The anticoagulant were almost used in all of COVID-19 patients as a thromboprophylactic therapy. And the last thing is the tocilizumab, which is used in cytokine storm patients. So after all of these medications that have been discussed, our question is, what's the clinical outcome of COVID-19 patients using all of these treatment protocols at King Abdullah Medical City? Our research based on the KMC protocols, which based on the WHO recommendation. The primary objective is to assess the clinical outcome of COVID-19 patients who's using different treatment at KMC, and the secondary outcome is to assess the demographic, the clinical presentation, and the comorbidities of those patients. A single-centered retrospective study. We included all patients who have been admitted to KMC with positive PCR tests, either before or after the admission, and we excluded all patients who have been discharged, transferred, or expired within 5 days of admission. The data were collected according to the demographic, clinical presentation, underlying comorbidities, and patient severity, and the treatment, which is the most important thing, and the outcome of this treatment. We enrolled in our study 120 patients. 38 of them were excluded because they were outpatients. 92 of them were classified as, 45 of them were excluded because they were discharged or transferred to other hospitals within 5 days or less, or the remaining, which are 38 persons who have been admitted with more than 5 days and included within our study. The baseline characteristics of those patients, we classified the age according to 3 categories. Most patients and the majority of the patients were elderly and male also, and we have here 36.8% of obese patients. The majority of patients were Saudis, and we have 13.2% of smoker patients. The comorbidities that have been shared between the COVID-19 patients were the hypertension, which is about 71%, cardiovascular disease about 55%, and diabetes mellitus, which is about 52%. We have also other diseases, including the respiratory disease and the renal impairment patients. According to the blood type, there is no relationship between the COVID-19 patient's severity of symptoms and blood type, but our studies show that the O-negative blood type, which has 2.6% lesser than the other blood types. The majority of the patients came to KMC within 1 to 3 days of onset of symptoms. The most commonly symptoms were recorded as fever, cough, and shortness of breath, and about 36% of symptoms were GI symptoms, and the other were headache and fatigue. The patient severity, half of the patients were mild, and the remaining were moderate and severe. The treatment protocol based on according to each patient's need, as I said. So we have here most commonly used treatment, the antiviral and the antibiotics. Then we go for 44% of hydroxychloroquine, and then corticosteroid, tocilizumab, and triple antiviral therapy. The triple antiviral therapy, as I discussed before, it contains lopinavir, ritonavir, and ribavirin, and interferon. Low rate of mortality of COVID-19 patient who was using corticosteroid, which is about 5%, in compared to patient with not use corticosteroid. The corticosteroid mainly used in patients with severe cases. Here we have different corticosteroid medication. As we can see here, there is no statistical differences in different medication of corticosteroid. The antibiotic, we have here high rate of mortality of antibiotic users COVID-19 from 15% to 0%, the 0% which is the non-users. The antibiotic were used in cases of co-infection, severe cases with COVID-19. The triple therapy combination, as we can see here, there's no statistical differences between the expiration and between the discharged patients. The hydroxychloroquine, which has the same thing, there's no statistical differences. The tocilizumab, there's no lot of sample size that we have taken in tocilizumab patients, so there is no huge number of tocilizumab patients, as we have only two patients and they expired. Our conclusion is corticosteroid, which had decreased the rate of death among COVID-19 patients in severe cases, the antibiotic, which used mainly in co-infected patients to reduce the rate of mortality, and the hydroxychloroquine, and the hydroxychloroquine and the triple antiviral therapy doesn't show any statistical differences. The tocilizumab were used in only 2 patients and they expired. The recorded comorbidities were hypertension, diabetes mellitus, and cardiovascular disease, including the respiratory and the renal impairment patients. Most of symptoms were fever, cough, and shortness of breath. Our limitation was a retrospective study with short sample size and lack of control arm with limited number of patients. Our future plan is to assess the safety profile of all of these medications, including the adverse effect and the drug-drug interactions, and we will done it, inshallah, in multi-center study. Our recommendation is to document the different blood type of COVID-19 patients, to document the safety profile of all of these medications, and to follow the WHO recommendation regarding to those medications. I would like to thank you all for listening and thank Dr. Reggio and Dr. Saha and Christine for letting us this opportunity in researching this research. Thank you so much.
ابتدأ التصويت. انتهى التصويت. أما الآن مع العرض التقديمي الثامن بعنوان Patient Reported and Quantitative Voice Outcomes in Patients Undergoing Thyroidectomy at King Abdullah Medical City, Mecca.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. I am Abir Al-Harthi. I am from Project 7. Today, I will present our project. Thyroidectomy remains one of the most common performed operations in our setting. In our setting for the various pathologies, ranging from multinodular goiter to thyrotoxicosis to malignancy. So during this surgery, the surgeons take a precaution to receive the nerves are important in the phonation, which is the recurrent laryngeal nerve and the external branch of the superior laryngeal nerve. So, extensive data is Extensive data is available in the literature reporting that the incidence of the recurrent laryngeal nerve during thyroidectomy, it is the report a vocal cord paralysis rate around 0.5 to 2%. Post-thyroidectomy dysphonia is 14 to 19%. So, however, voice changes are common after the thyroidectomy, even in absence of the effort of the vocal cord paralysis. The majority of patients are counseled that post-thyroidectomy voice change are rare and temporary. So, no study to date has investigated the actual patient experience of the living with the post-thyroidectomy voice change. So, with this background, we will plan our study, which title is Patient Reported and Quantitative Voice Outcomes in the Patient Undergoing Thyroidectomy at King Abdullah Medical City. Through this study, we will answer the question, is there any association between the surgery patient received voice-related quality of life and the quantitative voice outcomes in the patient who underwent thyroidectomy? So our objectives are primarily to compare patient-perceived voice changes with the quantitative voice measure changes in the first post-operative year derived from the instrumental voice evaluation. So, secondary, to assess the effect of the age and the type of the thyroidectomy, hemi or total, neck dissection, radioactive iodine, family structures, and the educational level, and speech therapy on patient-reported and the quantitative voice outcomes. So, study design, we plan to conduct a cross-sectional mixed method study, qualitative and quantitative. This study duration 1 year. We are going to collect the patient who underwent thyroidectomy at King Abdullah Medical City from the December 19 to the June 2020, either benign or malignant thyroid, and contact with them through the mobile phones and ask him the question about the thyroid surgery, which matched 1 to 4, to age, the sex parity, healthy population, relative, and relatives are the KMC emboli, we excluding the professional voice user and the voice surgery. After we get the consent from the patient to participate in our study, we will send the online survey, which know the voice handicap questionnaire, which is the validated questionnaire in Arabic language. This is a questionnaire giving us the idea about the voice-related disability. And after that, we ask the patient to send 3 voice samples. The first is a voice sample through the WhatsApp, and they say the letter E, the first sample in the soft speech, and the second for the normal speech, and the third in high pitch. After that, we use this sample to analyze by the Pratt software, which is for the acoustic analysis, to get the parameters, the fundamental frequency, jitter, shimmer, and the harmonic to noise ratio, dysphonia severity index. So after the obtaining of the data, After getting the data, the analysis will be done by SPSS 25 version. We use the PER t-test and the chi-t-square linear regression. So the level of the significant when the p-value less than or equal 0.05. So our result, inshallah, published in the peer-reviewed journal. This is the software, Pratt software, for the 4-second voice sample. And this is when the voice analysis, we get the value for parameters for the fundamental and the jitter and the harmonic to noise voice ratio. So We calculating of the dysphonia severity index score vary from the 0, 5 to plus 5, the value close to plus 5 significant normal voice, but the values near to minus 5 significant a dysphonic voice. So, we evaluated in the available time after the getting the IRP approval for patient and for healthy individual based on the age group and the gender matching. All patients are female and the mean of the age it is the 55. So based on the FNA cytology diagnosis, the majority of patient diagnosis with the basis the 3 and the total thyroidectomy was done for the all patient. So one patient with one cord palsy getting after the vocal cord, after post-operative vocal cord. One patient had cord palsy after the thyroid surgery. So when we ask the patient, pre-op counseling is satisfaction, 3 patients with moderate and 1 patient with very much, and the majority of patients has moderate fear of losing voice, and about the post-operative voice change perception, 50-50 patients say, 2 patients with yes and 2 with no. 1 patient are given one given speech therapy. When both the groups are compared, we found the values of the fundamental frequency and the jitter peak comparable equal, but there was a statistical significant difference between the shimmer and pitch and the harmonic to noise ratio and dysphonia severity index. All the 3 parameters were lower in the thyroidectomy groups. This is important to understand the respect the pitch of the voice, which is basically due to the function of the cricothyroid, which is innervated by the external branch of superior laryngeal nerve, which is the very thin nerve that's very likely to get damaged during the surgery. So here, the thyroidectomy group had 1 patient with the vocal cord palsy who had a severe voice handicap index, but it is also surprising to see patient with the normal vocal cord function to have moderate voice handicap score. When we compared the dysphonia severity index with the voice handicap index score, we see a negative correlation between the both. As seen, this is scatter plot, where the majority of the patient with the good dysphonia severity index score had this voice handicap as compared to 1 patient, as seen here. Okay, seen here who had a higher voice handicap score and the poor dysphonia severity index. In the left picture, when compared between the grade of the voice handicap and the dysphonia severity index, based on the population type, we find the thyroid surgery patients across all the 3 grades of the voice handicap and varied of the dysphonia severity index. So, in the right pictures, was done with the respect of the perception of voice change. Patients who received their voice change even after having the documented normal vocal cord had lower dysphonia severity index score and moderate voice handicap. So further analysis was not done in the view of the limited sample size. So our conclusion, thyroidectomy patient, even with a mobile vocal cord, do suffer from the impaired communication issues. Majority don't undergo speech therapy sessions. Neuromonitoring is not routinely used. A prospective study design is also planned based on this pilot project's finding. Strength, novel use of mobile technology, no patient contact received in COVID-19 era, sensitive analysis through software, limitation pilot project, small sample size, and single center study. Our aim to improve the voice-related quality of life in thyroidectomy patients through active surveillance of the voice-related issues for timely therapeutic intervention. So we're extremely grateful for Dr. Suhail and Dr. Suha Al-Morsi. Thank you for listening.
ابتدأ التصويت. التصويت. انتهى التصويت. أما الآن مع العرض التقديمي التاسع بعنوان Thyroid Tumor Features Impact on Lymph Node Metastasis in Papillary Thyroid Carcinoma Patients in KMC Retrospective Cross-Sectional Study.
Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Zansy Sivri. I'm going to present on behalf of my group 10. Our title is Thyroid Tumor Features Impact on Lymph Node Metastasis. Our title is Thyroid Tumor Features Impact on Lymph Node Metastasis in Papillary Thyroid Carcinoma Patient in Head and Neck Surgery Department at KMC. This is a retrospective cross-sectional study. First, we want to declare that we have no conflict of interest. This is the IRB approval. Papillary thyroid carcinoma is the most common kind of thyroid cancer. Recent study showed that it's increasing in Saudi Arabia. It has a very good prognosis, but it has a high recurrence rate. Lymph node metastasis is an important factor when determining the recurrence risk and the general prognosis of the patient. Previous study classifies lymph node metastasis as central or lateral, but without elaboration of the number and exact lymph node metastasis. Our primary objective is to evaluate the association between the size of the tumor and the number of lymph node metastases in papillary thyroid carcinoma patient in KMC. Secondary objective is to evaluate the correlation between the tumor marker level and number of lymph node metastases in BTC patient to determine the association between specific histological subtype of BTC and number of lymph node metastases to determine the association between the site of the tumor and number of lymph node metastases. This is our method. The study design is a retrospective cross-sectional study setting in head and neck surgery department at KMC. Patient from endocrinology department were excluded. The study population patient with BTC and lymph node metastasis at head and neck surgery department from 2009 to 2020. Inclusion criteria: pathologically confirmed BTC patient with the lymph node dissection. The exclusion criteria: 100.3 patients were excluded. The exclusion criteria we have two. The first one is BTC patient without neck dissection, and the second one is thyroidectomy for BTC patient done outside KMC. The sample size after applying the inclusion and exclusion criteria: 22 patients were included in our study. Data collection: we collected from the patient's file. Data entry and analysis: SPSS version 23. This is our result. We find the gender equal in both gender, 50% male and 50 female. The age is more in less than 40, which is 54%. The multifocality were found in 54%. Bilaterality is 50-50. We observed that the neck actually is divided into levels. We observed that there are some levels are more affected than the other. The most affected level is level 4, 3, and 2, respectively. As shown here in the picture, you can see the level. These are the analytical studies, the size of the tumor with the number of lymph node metastases. In the x-axis, this is the tumor size, and you can see that as the tumor size increases, the number of lymph node metastases also increase. And the tumors here in the right one, the tumor site with the number of lymph node metastases, number of lymph node metastases is more in the tumor which if it was bilateral. Histological subtype with number of lymph node metastases. Actually, we have 22 patients. 20 of them were conventional, so we couldn't find any statistical significance from this. Thyroglobulin post-operative with number, and also this is not significant. The conclusion, our study shows that there is a relation between the size and the number of lymph node metastases. However, the p-value shows it's not statistically significant. The study demonstrates that there is no association between the tumor marker and the site of the tumor with number of lymph node metastases. We couldn't confirm the association between the histological subtype of BTC and number of lymph node metastases. The most common level affected are level 4, 3, 2, respectively. Finally, we want to thank Dr. Asuha, Mr. Maher, Mrs. Dua, and all the staff of research department at KMC. The limitation, the sample size, we want to increase the sample size in the future, and also COVID-19 and limited time. We want to recommend to increase the sample size and make it multi-center study. We need more research about BTC in Saudi Arabia. The future plan, we will inshallah continue the research until publication. Any question? Thank you very much.
ابتدأ التصويت. انتهى التصويت. أما الآن مع العرض التقديمي العاشر بعنوان Outcome of Discharged COVID-19 Patients from Emergency Department, a Tertiary Care Hospital Experience Retrospective Cohort Study.
Good morning, everyone. I'm Yasser Saleh, presenting Project 3, outcome of discharged suspected COVID-19 patient from emergency department, tertiary care hospital experience, retrospective cohort study, principal investigator Dr. Muhammad Al-Wadi'i, and the co-investigators Dr. Anas Bana, Yasser Saleh, Bassam Al-Harthi, Omni Kutbi, Rinad Al-Gaidi, and Nada Tahir. This is the outline of the presentation. All authors reported no conflict of interest relevant to this article. Okay. As we know, COVID-19 is a new disease, affect all the healthcare system in a short period, especially on the emergency department, resulting in overwhelmed and depleted resources. So we don't have enough evidence to manage these patients safely, and we don't want to be scared to admit any patient to the emergency department to avoid the overwhelming and inappropriate resources utilization. Since the beginning of the pandemic started, there is a continuous changing in the recommendations and in the guidelines, and approaching to the patient or to these patients. So in the beginning, they said admitted all the patients, all suspected patients, then changed to the admitted only the high risk group, and the resources started to be utilized. Here we are looking for balance between appropriate hospital resource utilization with safety of emergency department discharging decision in presence of lack of evidence. So our research question, what is the outcome of suspected COVID-19 patient discharged from emergency department who were swabbed and the result came positive afterward? Hence, we aim to assess the clinical outcome of suspected COVID-19 patient who got swabbed and discharged after presenting to the emergency department in the King Abdullah Medical City, and their result came positive afterward. Furthermore, we aim to find out the best measures for discharging suspected COVID-19 patient from emergency department. So we conduct our study, retrospective cohort study in KMC emergency department from 5th of March 2020 to 5th of June 2020. These are our inclusion and exclusion criteria. We excluded all patients discharged against medical advice at KMC emergency department, also all absconded patients, also and patients younger than 14 years, as the KMC School of Service limited to treat only the adult patient. So our data collection done in 2 steps. Step 1, data related to the clinical demographic and clinical characteristics, and KMC revisited. Were collected by reviewing the electronic file from the TrackCare MR system. And the second step, then data related to the outcome and data related to the outcomes and the quarantine, location, length, seeking medical advice, non-KMC revisit. These were obtained by phone call follow-up, standardized patient phone call follow-up. And our data is directly entered to SBS. Here are our outcome assessment. Primary outcome is oriented patient looking for death or admission to any critical care unit or medical ward, admission to any healthcare facility or revisit to any emergency department within 14 days, revisit to any other clinical within 14 days, calling EMS, calling any virtual healthcare services, or recovery. And the secondary outcome, we're looking for association or significant association of the outcome of the patient regarding with vital signs, age, comorbidity, nationality, and NEWS2 score, national early warning score, and worsening symptoms. Okay. Here we scanning and finalize our patient's sample size. We find 605 patients who got swabbed in the emergency department. 476 patients were negative, so we are excluded them. And additional 63 patients were admitted, so that this type of patient not fit the inclusion criteria. An additional 15 patients, were outside the study period. Finally, we end with 51 patients. Only 11 patients has revisited to the healthcare facility and our emergency department. The majority of them were admitted to the hospital. And unfortunately, we have one mortality case admitted to the other hospital. And we don't have a lot of information about this case because our study conducted in a single center. Here, descriptive analysis for the total population. There is no big difference in demographic data. The minority of population is a smoker and ex-smoker. Also here, the most common presenting complaint was fever. Also, the most common comorbidity was diabetes. Majority of patients triaged as level 3 and scores as low risk. Here, a significant difference. Here, in comparison between revisited patient and non-revisited patient. Okay, there is a significant association between worsening symptoms within 14 days after discharging from emergency department with the revisited patient. Also, there is a significant association in seeking medical advice with the revisited patient within 14 days after discharging from emergency department. Here we have only diabetic significant association between diabetes and revisited patients. Also, and in the vitals, oxygen saturation, there's a significant association between the oxygen saturation and revisited patient. Majority of revisited patients came with low oxygen saturation. Here, we don't have any significant association in the demographic data or in the triage level or in the rest of symptoms. Also, the majority of presenting complaint due to the revisited patient is shortness of breath. Here, majority of admitted patients, 63%. The aged mean 58. Also, there's here the outcome of admitted patient. Okay, was it 62.5 discharged safely? There is a significant difference. Significant association worsening of illnesses and symptoms with the readmitted, also in seeking medical advice. So, summary of important result: 22% of participants at the study revisited the emergency department. 73% of these revisited patients were admitted. There was statistically significant relationship at both oxygen saturation and diabetes in the revisited patient. Also, there was a significant association between the worsening symptoms and seeking medical advice in admitted patients. These are in conclusion, and these are limitations and recommendation. Many thanks for research centers and CRISP team, especially for Dr. Soham, Maher Al-Hazmi, and Dua and Wala. Thank you.
تصويت. انتهى التصويت. أما الآن مع العرض التقديمي 11 بعنوان Evaluation of Medical Field Students' Knowledge of Infection Prevention and Control Practices during Clinical Years in Saudi Arabia.
Good morning, everyone. I am Rinad Al-Hazmi. I'm a third-year medical student from Al-Qura University. I'm a member of Group 8, and today I'll be presenting our project, which is titled as Evaluation of Medical Field Students' Knowledge of Infection Prevention and Control Practices During Clinical Years in Al-Qura University, Makkah, an observational cross-sectional study. So, as we may know, infectious diseases can be spread easily, especially throughout hospitals, and healthcare providers have got a high risk of getting infected since they have a high chance of encountering infected patients. But fortunately, most of them already have got enough knowledge and experience regarding infection control procedures and protocols. Meanwhile, on the other hand, medical field students also have a high risk of getting infected. And they can get infected by doing the simplest things, such as doing an examination or even taking history. So it's very important to make sure that these medical field students have got enough knowledge and awareness regarding infection control procedures and protocols, and that they're able to follow them correctly. So in an older study, it was found that the lack of knowledge and compliance of infection control measured by healthcare providers was partially explained by the deficiency of the curricular content of medical field students. Gaps were also found. First of all, these kind of studies were kind of limited in Makkah, and also these kinds of studies didn't include all majors such as respiratory therapy, which was included in our study. So for the aim and objective, first of all, we want to evaluate the medical field students' knowledge and awareness of infection control practices, prevention, and procedures during clinical years. We also wanted to evaluate students' knowledge about the extra precautions that should be taken during world pandemics, such as COVID-19 in our current situation. So as mentioned in the title, the study was a cross-sectional study. It was conducted on undergraduate medical field students in their clinical years from Al-Qura University, which included medicine, dentistry, nursing, and respiratory therapy. Students in their academic years and interns were excluded from this study. The data was collected via an online questionnaire, and SurveyMonkey was used to distribute the questions. So here are the questions from the questionnaire. I'm just going to go through them really quickly. So it was split into 4 categories. The first category included the students' info, which asked about the general information for the students, such as nationality, gender, and so on. Then the second category was about knowledge regarding infection control, and it included some questions regarding the general information about infection prevention and control. Then in the practice of infection control category, there was a question that included whether or not these medical field students have got a special training about the extra precautions that should be taken during the COVID-19 infection. And last of all, attitude regarding infection control. Most of the questions were about the N95 mask. So for the results, I'll start by describing the sample that we got. Most of the participants were female, with 76%, about 76%, and most of them have received a kind of training or orientation about infection prevention and control. And as mentioned before, we had 4 colleges in this study, which included medicine, dentistry, nursing, and respiratory therapy. And more than half of them were medical students. Juniors were more in this study, as seen right here. So these are the juniors, so they were more. And most of them were Saudi and lived in Mecca. So for the overall awareness, there was a significant found between the 3 categories where the highest percentage was for the practice section and the lowest was for the knowledge. So now if I interpretate each category individually, each category individually, starting with knowledge and comparing it with different variables, we can see here that although the number of females participating in this kind of study were more, it actually didn't show any significant difference with a p-value of 0.6. Meanwhile, the batches showed a significant difference where juniors had more knowledge percentage than senior batches. And in colleges, they were very close to each other as seen here, so there wasn't a significant difference with a p-value of 0.15. Okay, so in the practice, neither gender or batches had a significant difference with a p-value of 0.76 and p-value of 0.86 respectively. And it was found that the medicine had a slightly higher percentage of practice percentage regarding practice. Okay, so attitude. Between all these categories, it was found that there was a significant difference between male and female in attitude. With male and male were about 60%, with a p-value of 0.11. And the batches were also significantly different, as shown right here. So junior batches had a higher percentage of attitude, with a p-value of 0.008. And as shown here in the colleges, dentistry had a percentage of 41%. Meanwhile, the other colleges had a percentage between 50 to 55%. So in conclusion, it seems like most of the medical field students do not have enough knowledge of infection prevention and control practices during their clinical years. We had some limitation in our study. First of all, it was time. Time was really tight. Also, the number of participants wasn't as high as we expected, and the study can't be generalized on all university. For the suggestions, we suggest doing this study on each college individually and using a bigger number, and doing this study in more Saudi Arabia universities and comparing the outcomes. Thank you.
انتهى التصويت. التصويت. أما الآن مع العرض التقديمي الثاني عشر بعنوان the prevalence and associated risk factors of autosclerosis among adult patients in Mecca, Saudi Arabia, a case control study.
Bismillah ar-Rahman ar-Rahim. Good morning, everybody. My name is Jawahir Fada Sharif, and I'm a fourth-year medical student. I'm actually happy to be here today with you to talk about our study on behalf of my group, which is the prevalence and associated risk factors of autosclerosis among adult patients in Mecca, Saudi Arabia. Here is our content slide. I'm going to talk about those 5 items in the next 7 minutes, starting from the introduction. So, what is autosclerosis? Autosclerosis, in the condition of autosclerosis, there is a bony formation develops around the stapes, foot plates, that impedes the movement of it, resulting in prevention of the conduction of hearing, of the normal hearing process from the outer ear into the inner ear, and hence resulting in the conductive hearing loss. Autosclerosis is generally identified by 3 tests, which are tympanometry, pure BTA, pure tone audiometry, and finally the stapedial reflexes. Autosclerosis is treated by the surgery, which is the most common option and the most successful one. Actually, autosclerosis in our society or in our country is a rare disease. Furthermore, according to WHO, the global prevalence is less than 1%, and according to a study conducted in 2009 by Melissa Theis, the exact etiology of autosclerosis and associated risk factors is still a matter of debate, especially in our country, because there is no enough data on the prevalence and the associated risk factors of autosclerosis. So our study will be the first study to measure the prevalence of autosclerosis in Mecca, and then we will generalize it on the whole kingdom. And this is our first primary objective. In the second primary objectives, we are aiming to determine if there is any association between the exposure to the risk factors and the development of the autosclerosis. Our major secondary objective is to evaluate the post-operative complications and the improvement after stapes surgery. Moving to the methodology. So our study design is a case-control disease, and this is because, as I mentioned, it's a rare disease, and we are aiming to measure or determine if there is any association between the risk factors and the development of the condition. Our study has been conducted in King Abdullah Medical City, in the Holy Capital, and in the population we included all adults who attended to ENT OBD department and were diagnosed as autosclerosis during the study period, which is from 2010 to 2020. Those 2 are our inclusion criteria. Furthermore, we excluded the children. For the sample side, since there is no prevalence studies, we included all available cases in CAMS Hospital. We collected the data of cases and controls from the medical records of CAMS, and then analyzed the data by using SPSS program version 24. Actually, our study has been conducted through 2 phases. In the first, we collected the data of cases and controls during the study duration, but unfortunately, it was a very short number and a small size. So we aim to increase the number by extension of the study duration in the next phase. Our result shows that the prevalence of autosclerosis among CAMS population is 31.5%, and the prevalence of autosclerosis in Mecca was estimated as 2 patients of having autosclerosis among 100,000 population. Moreover, we compared between the cases and controls by using chi-square according to the demographics in this slide, in the second according to the risk factors. We found that there is no statistically significant differences. This is due to the small size number, the small size of the cases. But we can conclude some of the major findings, such as in the gender, we found that 58% of the cases were female, and in the age, we found that 57% of the cases were in the adulthood range, and 58% of the controls were in the younger age. Here, same as we said before, no statistical significance, as you can see in the bottom line of the slide, of p-values. But we can also find some of the major findings, such as in the infection. We found that 89% of the controls had previous infection, whereas only 11% of the cases had the previous infection. Moving into the evaluation of the improvement after stable surgery. So as you can see here, and according to WHO, the normal BTA was determined as less than 25 decibel. So in the y-axis, we have the threshold of BTA measured by decibels. In the x-axis, we have the frequencies, and we can show that there's a statistically significant improvement between the post-BTA, which is the navy line, and the pre-BTA, which is the orange line. The post-BTA, as it is shown here, almost all of it is falling in the range of the normal hearing. I'm just gonna show, okay. I wanted just to point, there's no pointer, okay. Moving to the last result, we found out most of the patients who underwent stable surgery, i.e. 43% of them didn't experience any complications. In conclusion, the estimated prevalence of autosclerosis in Mecca was less than the global prevalence, and none of the risks shown any statistically significant result, and the patients who underwent stable surgery showed an improvement. Finally, does our study help other countries with higher prevalence of autosclerosis to decrease the incidence of autosclerosis? And this will be continued in the next phase, inshallah. Thank you for listening, and here I just attached the barcode if you are interested. I added some of the details in the notes. Do you have any questions?
بدأنا التصويت.
Thank you.
انتهى التصويت. أما الآن مع العرض الثالث عشر بعنوان Prevalence of Depression among Type 2 Diabetic Patient at King Abdullah Medical City.
Assalamu alaikum. I am Anas Zahrani from Project 4. Our project is about prevalence of depression among type 2 diabetic patients at King Abdullah Medical City. This is our outline for our presentation. According to the World Health Organization, diabetic mellitus is the seventh cause of death worldwide, taking the lives of 1.6 million people worldwide in 2016. According to screening from Saudi General Authority for Statistics, in 2018, prevalence of depression was 8.5 of all Saudi population, and in Mecca province recorded the highest prevalence of diabetic mellitus, which was 10%. As we can see here, Mecca province was the highest prevalence of diabetic mellitus. There is a relation between depression and diabetes. In 2019, there is a meta-analysis study shows that depression was associated with increased risk of incidence of macrovascular and microvascular diabetic complication. Also, a study in 2019 in Mecca City, a cross-sectional study shows that the prevalence of depression among diabetic patients in Mecca City was 21.3%. In our study, there is no previous researches that study the prevalence of depression among type 2 diabetic patients at King Abdullah Medical City, as King Abdullah Medical City is a tertiary hospital that is expected to provide a high level of health care. It's important to study the prevalence of depression among type 2 diabetic patients and its associated factor. So our objective is to find the prevalence of depression among type 2 diabetic patients at King Abdullah Medical City. And our other secondary objective is to find the association between glycemic control and depression via HbA1c measurement, to identify the association between diabetic mellitus chronicity and depression, and to find the prevalence of type 2 diabetic patient complications among type 2 diabetic patients with depression, and to identify the associated factors, BMI, socioeconomic status, lifestyle among type 2 diabetic patients with depression. Our study design is observational cross-sectional study, and our population is type 2 diabetic patients following in the outpatient clinic in King Abdullah Medical City, aging between 18 to 70 years during the 2020 year. Our estimated sample size is 385 patients. We use a tool in our study, which is a questionnaire for measurement of depression. It is Patient Health Questionnaire 9, BHQ9, which is a valid, short, easy-to-manage questionnaire to measure the depression and its severity for each patient. Our methodology is consisted of 3 steps. The first step is a list of diabetic patients follows an outpatient clinic at KMC, aging from 18 to 70 year during the 2020 year, was collected. Every participant was given a code number to ensure blinding and confidentiality. Then the second step is data collection via electronic data collection form, which consisted of 2 parts. The first part is an interviewing questionnaire via phone call, which filled after obtaining verbal consent from patients. The questionnaire collects the demographic data, socioeconomic status, presence of other chronic disease, and valid Arabic version of BHQ9 questionnaire to assess the depression. And after that, the second part is for lab values, HbA1c, lipid profile, and renal function test will be collected from patient electronic file. The third step is data entered into SPSS then statistical analysis was performed. As we can see here, the characteristic of our study sample, our study sample were small. They were 14 patients up to the date of this presentation. We made an interview phone call with them and assessed their depression, and we collect their lab values from the data and analyze it. The mean age here is 55 year for our sample. And other characteristics for our sample, we can see that the majority of them were male and Saudi and married, and a majority of them were non-smoker also. For our main goal, for our sample, the prevalence of depression were 85.7% were depressed, while just 14.3% were non-depressed. Also, BHQ-9 questionnaire assessed the severity of depression. As we can see here, majority of them were minimal depressed of our sample. The severity of their depression were minimal. And for moderate and moderate severe and severe depression was low. They are in total 35% in total. As our study conducted in the period of COVID-19 pandemic, we asked the participants in our questionnaire whether their symptoms appear before COVID-19 pandemic or after it, and 56 of the participants say that their depressive symptoms appear before COVID-19 pandemic. We try here to assess other associated factors with the prevalence of depression among the diabetic patient. We noticed that the diabetic, the uncontrolled diabetic and smoker diabetic and diabetic with other comorbidities have in general higher prevalence of depression than the controlled and non-smoker and diabetic patient with only without any other comorbidities. But actually, we didn't find any statistical significance for this, and this is maybe because our small sample size. In conclusion, in our study, the prevalence of depression among type 2 diabetic is 85.7, therefore it is higher than the undepressed. There is many possible causes for this high prevalence. One of it is our sample size is very small sample size, and this is because the time was very limited. The second thing, this study conducted at King Abdullah Medical City, which is a tertiary hospital that dealing with more complicated cases. The third possible causes is this study conducted in the period of COVID-19 pandemic, which is maybe affected the result. We recommend a regular screening for depression and treating the depressive symptoms in diabetic patients, which may improve glycemic control and quality of life. And we recommend a multidisciplinary care approach for diabetic patients to control the HbA1c and reduce the comorbidity. The limitation of our study, this study is included the patient attending to King Abdullah Medical City, so the result cannot be generalized on all diabetic population, but it may be generalized on a similar tertiary hospital like King Abdullah Medical City. Also, this study is a cross-sectional study, therefore the causal relationship cannot be established due to the bidirectional relationship between diabetes and depression. Our future plan, we aim to complete this study on the larger sample size. We aim to collect data from 385 participants. We aim also to investigate for other associated factors which may affect the prevalence of depression among type 2 diabetic patients. This is the reference for our presentation. I would to thank Dr. Suha and Dr. Maher and Dr. Rom and Dr. Amin and all the CRISP team members for their time. Thank you.
انتهى التصويت. أما الآن مع العرض الرابع عشر والأخير بعنوان Prevalence of Obesity in Hospitalized COVID-19 Patients at King Abdullah Medical City, Mecca, Saudi Arabia.
Assalamu alaikum. My name is Abir Al-Jahdali and I'm here today to talk about project number 13 titled Prevalence of Obesity in Hospitalized COVID-19 Patients at King Abdullah Medical City, Mecca, Saudi Arabia. Our mentors are Dr. Ali Al-Bahrawi and Dr. Samah Milibari. Before I start, I would like to thank Dr. Soha and the rest of CRISP 2020 team for their help. I would also like to state that the authors declare no conflict of interest. Almost half of the previous presenters talked about COVID-19, not to mention that it's all over the media, so I guess you're all well informed about the impact of the disease. Now, I will try to draw your attention to another pandemic. Obesity, defined by WHO as BMI greater than or equal to 30 kg per meter square, is a known medical condition. It has been identified as a risk factor for several comorbidities, including diabetes, COPD, and cardiovascular diseases, all of which are risk factor for severe form of COVID-19. In Saudi Arabia, the prevalence of obesity is 35.4%. This high prevalence should alarm us to look into whether obesity is actually linked to severe outcome of COVID-19. So we have a pre-existing pandemic, which is obesity, a new emerging pandemic, COVID-19. What do you think would happen when the two of them coexist together? To answer this question, we looked into several studies. Many of them reported obesity to be associated with adverse outcomes of COVID-19. However, some other studies found poor correlation between the two of them. Given that fact, there is still a gap in identifying factors behind the adverse outcome of COVID-19, specifically in obese patients. Also, no studies have been done regarding this problem in Saudi Arabia or even in Middle East. For that reason, we decided to conduct this study, and we aim to determine the prevalence of obesity and the ratio of obese patients admitted to critical care among hospitalized COVID-19 patients at King Abdullah Medical City. Our secondary objective was to compare the mortality, length of hospital stay, critical care admission, and need of mechanical ventilation in obese and non-obese patients who are admitted to KMC for COVID-19. The study was an observational and analytical retrospective cohort study from prospectively collected data. We included all patients aged 18 years and above who are admitted to KMC with confirmed COVID-19. We excluded pregnant women, patients less than 18 years old, and those who were not admitted. The data were from review of medical records and the duration from the first announced COVID-19 case in Saudi Arabia, which was March 2nd, till June 30th. Excel sheet was used for data entry, SPSS software for statistical analysis, The data were described with the mean standard deviation, a chi-square for categorical variable analysis, and Mann-Whitney test for comparison between groups. Out of 155 patients, 60 patients were obese, representing 39% of total patients. With a mean age of 59.5, the majority of obese patients were females, with a prevalence of 61%. There was no significant difference in the ratio of ICU admission, as 36.7% of obese and 35% of non-obese patients were admitted to ICU. However, there was a difference in the need of mechanical ventilation, as 25% of obese patients compared to 15% of non-obese patients required mechanical ventilation. For the complications of COVID-19, patients with obesity were more likely to develop pneumonia, as 41% of them did, compared to 20% of non-obese patients. 25% of obese patients developed acute respiratory distress syndrome, whereas only 4.2% of non-obese patients did. 10% of obese and 44.2% of non-obese patients developed multi-organ failure. For the outcome, 43% of obese patients were discharged, and 20% had died, compared to 16% of non-obese patients. In conclusion, the prevalence of obesity and the ratio of ICU admission was statistically insignificant. However, obese patients were at higher risk for pneumonia, acute respiratory distress syndrome, and the need of mechanical ventilation. So obese patients diagnosed with COVID-19 should be carefully treated and managed, given the possible higher risk for adverse outcome of COVID-19. Our study has several limitations. First, the retrospective study design is suboptimal compared to a prospective study that could have been more accurate in follow-up and assessment. However, our data are still valid, as we collected almost all the data on variable of interest for our study. Another is that our sample size is small, but we consider this a pilot study for our future project that will involve more centers and larger sample size. Another is that the KMC is a specialized center, meaning that most of our cases are complex cases and not representative for the general population of Saudi Arabia. So to reduce the selection bias, more studies in general in community hospitals and COVID centers are needed. Lastly, we were confined to a short duration given the time frame of CRESP. As I mentioned, one of the challenges we faced is the limited time, as we only got the ARP approval last Thursday, giving us only 1 week to collect and analyze the data, yet we managed to do so. We also managed to get the abstract done. While we recognize the limitation, we hope that our study will encourage additional researchers to further study the effect of obesity on COVID-19, because the more studies we have, the more likely we identify the cause of the relation between obesity and adverse outcomes of COVID-19, or to study the effect of weight independently from other variables. Sooner or later, COVID-19 will be eradicated. However, prevalence of obesity will probably keep on rising. So our primary goal should be to get rid of this pandemic by promoting more weight loss campaigns and providing easily accessible obesity clinics. This is our abstract, which was distributed to you. And these are our references. Thank you.
ابتدى التصويت. انتهى التصويت. أي واحد قفل. نشكر فرق عمل البرنامج الصيفي للبحث العلمي لمدينة الملك عبدالله الطبية على ما تم تقديمه من عروض تقديمية وعلى ما رأيناه من جهود إبداعية مميزة. نسأل الله لهم التوفيق والسداد. أما الآن مع كلمة المدير العام التنفيذي الدكتور دلشد علي بن عباس علي، يلقيها نيابة عنه المدير التنفيذي للشؤون الطبية والإكلينيكية الدكتور علي الأحمري، فليتفضل مشكورا. خلاص أعطيه المايك تابع.
السلام عليكم ورحمة الله وبركاته. حياكم الله جميعا. حقيقة الواحد يسر بما سمع من أبحاث، من مجهود تكلل بعروض جميلة جدا. حقيقة النتاج المهم والرئيسي أنه الجميع فايزين بالمعلومات اللي حصلوها، بالمجهود اللي بذلوه، بالمعرفة الجديدة اللي توصلوا لها. الفائز الحقيقي هو كلكم، والمستقبل اللي بتظهرون فيه نتيجة لهذا العمل الجبار. فرصة تقدمها الإدارة التنفيذية للأبحاث في مدينة الملك عبدالله الطبية بالبرامج الصيفية. حقيقة مجهود جبار بذل الدكتور خالد لتنفيذ البرنامج في هذا الصيف، خصوصا في ظل الوضع الحالي لجائحة كورونا. نقول له جزاك الله خير. فريق العمل كامل معاه الدكتور زياد الحربي، الجميع المجموعة بذلوا مجهود رائع جدا. المجموعات اللي شكلت وفرق العمل اللي شكلت يعني ما قصروا، كان لهم بصمة، كان لهم مجهود، كان في دعم لوجستي من بقية الإدارات الأخرى. كل من كان له بصمة في الموضوع ذا جزاكم الله خير. حقيقة فرصة لكم أنكم تستفيدون من هذه البرامج، وإحنا مستمرين معاكم كمدينة طبية في عملية الدعم المتواصل وعملية البرامج. الدكتور دلشاد حقيقة مسرور أنه يحضر معنا، وكان حريص جدا في اجتماع غير مجدول مع الوزارة، هو اللي منعه من الحضور. سعيد أنا بتواجدي معاكم. جزاكم الله خير، الله يعطيكم العافية، موفقين، ونشوفكم إن شاء الله في مراتب أعلى وأبحاث أكثر، وبالتوفيق لكم جميعا.
طيب يعطيكم العافية. كما ذكر الدكتور علي، طبعا هذه بداية الطريق والجميع استفاد والجميع فائز معنا، وأهم حاجة أنكم تكملون مشواركم لجميع الفرق 14 وتطلعون بنشر بإذن الله تعالى خلال شهرين 3 6. بعض المجموعات السابقة في السنوات الماضية كانوا يستمرون إلى سنة، لكن في النهاية ينشرونها ونشر في مجلة قوية، ويكون هذا حقيقة النتائج اللي نبغاه. فأنا لا أعتقد أنه الإبداعات اللي شفناها اليوم أنها تقف إلى هذا الحد ولا تنشر للعالم أجمع من مدينة الملك عبدالله الطبية، خاصة أنه كثير منها كان له علاقة بكوفيد 19، وهي الأبحاث اللي نحتاجها هذه الأيام. فحقيقة إبداع من الجميع، ولكن كالعادة نحن نكرم، طبعا الجميع مكرمين عندنا، لكن نقيم الأبحاث ونكرم الثلاثة الأوائل حتى يكون في مجال للتنافس وفي المستقبل إن شاء الله يكون المخرجات أحسن بإذن الله تعالى. تفضلوا.
يسرنا الآن أن نتقدم بجزيل الشكر ووافر التقدير لكل من شارك وساهم في برنامج مدينة الملك عبد الله الطبية الصيفي للبحث العلمي. لجنة تحكيم البرنامج: الأستاذة أشواق عبد الغني الخواص، الدكتورة أحلام عمر المسعري، الدكتور زياد عزة الجندي،
تفضل يا دكتور. وعليكم السلام. تفضل خذيها وخليكي واقفة لأنكم منكم كلمات. تفضل الدكتور اللي بعده. خليكي معاه. دكتور خذيها منه. محتاج كلمة. دكتور تحطينا على الطاولة نحتاج كلمة.
المشاركين والمتعاونين من داخل المدينة الطبية:
طيب في الحقيقة نحن عادة نحب نسمع التعليق من المحكمين الثلاثة، فنبدأ بالدكتورة.
السلام عليكم ورحمة الله. معاكم أختكم أشواق قواص، سينيور إبيديميولوجيست. للأمانة أنا مبسوطة جدا بحكاية كوفيد. أنا شغالة از نائبة لمدير غرفة عمليات كورونا في مكة المكرمة في إدارة الصحة العامة. للأمانة ما شاء الله تبارك الله التجمع هذا يشرح الخاطر ويشرح القلب على قولهم في حكاية البحوث. أهنيكم بهذا الصرح الجميل والحماس اللي أنا شايفته في الطلاب. أهنيكم على الأبحاث اللي صارت بخصوص كوفيد. ما شاء الله تبارك الله مزيد من التقدم بإذن واحد أحد. طبعا أنا أتكلم من ناحية كمان إبيديميولوجيست، يعني ما شاء الله تبارك الله الميثودولوجيز اللي أنتوا حاطينها كانت بيرفكت، يعني ما شاء الله تبارك الله. اللي شايفته فيه أغلبهم ما زالوا طلاب في الجامعة، ما شاء الله الميثودولوجي كانت رائعة. فبالتوفيق والله يقويكم إن شاء الله ومزيد إن شاء الله من التقدم.
السلام عليكم. دكتورة أحلام المسعري. جهود تشكر من الجميع وخبرة تحسد عليها. برنامج له فترة طويلة وأتمنى أنه يستمر. المستوى أعلى من المتوقع دائما بجهود مركز التدريب والأبحاث وبجهود الدكاترة اللي مشاركين مع بعض الطلاب. أتمنى أنه البرنامج هذا يكون موجود في كل مناطق المملكة، وأنا متأكدة أنه كثير يحاولوا ينضموا له، فإن شاء الله يستمر، وهذا شيء مو مستغرب من إدارة الأبحاث صراحة.
بسم الله الرحمن الرحيم. أخوكم زياد الجندي، استشاري مشارك في قسم الأعصاب مدينة الملك عبد الله الطبية. السنة اللي فاتت كنت أنا منتور لزملائكم، الحمد لله حصلنا على المركز الثالث. طبعا كنت زعلان من المركز الثالث، المفروض نجيب المركز الأول، لكن بشكل عام ما في فرق بين المركز الأول ولا الثاني ولا الثالث ولا الأخير. كل الأبحاث جميلة ممتازة. قد يكون في اختلاف في التصويتات بناء على العرض المقدم، فمو معناته إنه البحث مو كويس، بالعكس كل الأبحاث كويسة. تحاولوا إنكم تنشروها قدر المستطاع. طبعا في دراسات كان الريكومنديشن أن تكملوها. عملية نشرها تعتمد عليكم بشكل كبير أكثر من الدكاترة، فأنتوا اللي تحددوا هل حتنشروا أو لا. إذا الدكاترة شافوكم ما أنتم متحمسين لكم تكملوا بحثكم ممكن توقف، لكن لو شافوكم متحمسين وتكملوا حيكملوا معاكم ويساعدوكم ويحاولوا أنهم يكملوا الداتا، وممكن يكون في تعاون مع باقي المستشفيات بحيث انكم تقدروا تكملوا الداتا حقتكم. فريقي انا قبل 3 أسابيع 4 أسابيع الحمد لله وصلنا اكسبتنس من المجله انه تم قبول نشرها ان شاء الله في الشهر القادم. فتشوفوا سنه كامله اشتغلنا، ومع رغم انهم كانوا سنه سادسه وتوقفنا، لكن كان في استمراريه، كان في متابعه، وصلنا للهدف اللي احنا نبغاه، وجدا سعداء سواء انا كمنتور جدا سعيد اني اشتغلت مع طلاب متميزين، وهم كمان كانوا جدا سعداء انهم هم اشتغلوا كفريق واحد ووصلنا للهدف اللي احنا نبغاه. فارجو انكم تشجعوا بعض على انكم توصلوا للهدف الاخير وهو نشره، سواء بنشره في الوضع الحالي او تسووا له اكسبانشن. هذا الشيء راجع لكم. اتمنى لكم التوفيق، واشكر الدكتور خالد ومركز الابحاث على دعمهم لهذا الشيء. ما توقعت انه خلال كورونا ممكن يكون في ريسيرشز، لكن سبحان الله بالرغم من جميع المشاكل اللي واجهت الجائحه الحاصله الا انهم مصرين على انه يكون في استفاده ليكم انتم، بحيث انكم تستفيدوا. بالنسبه ليهم اهم شيء الفائده ليكم لمركز الابحاث، انتم تكونوا المستفيدين. بالنسبه لينا مهمتنا ان نساعدكم ونعلمكم. شكرا للدكتور خالد وجزاك الله خير دكتور علي على حضورك.
طيب حقيقة أنا ودي أشكر الدكتور سعد الغامدي، كان المفروض يكون معنا أحد المحكمين ولكن لظروف خاصة ما استطاع يصل. فحقيقة نشكر لجهوده الجبارة المبذولة سواء في لجنة أخلاقيات البحث أو المفروض أيضا كان يكون معنا كمحكم من المحكمين ضمن ال3 المحكمين هؤلاء، ولكن ظروف معينة منعته من ذلك. نسأل الله أن ييسر أمره ويرفع عنه ما هو فيه، ونراه قريبا بإذن الله تعالى. تفضل.
المشاركين والمتعاونين من داخل المدينة الطبية: إدارة التسويق والاتصال المؤسسي، إدارة تقنية المعلومات والاتصالات، المهندس خالد البركاتي، المهندس ريان العمري، ريان العمري، الأستاذ إسماعيل البلوشي، المهندس سلطان زعتري، الأستاذ إبراهيم مجممي، المرشدين لفرق عمل البرنامج: الدكتورة شيرين خالد، الدكتور أنس بانا، الدكتور محمد الوادعي، الدكتور لايق أحمد، الدكتور سهيل سيد، الدكتورة رجاء مطاحن، الدكتور أمين الأهدل، الدكتورة فاطمة أبو العينين، الدكتورة أسماء حجاج. الدكتورة إشراق الأمين. الدكتور خالد بدر. الدكتور محمد العيسى. الدكتورة سماح مليباري. الدكتور علي البحراوي. الدكتور كريم شريف. الدكتورة غادة شلبي. فريق العمل على البرنامج الدكتورة سهى المرسي. الدكتور زياد الحربي.
طبعا الدكتورة سهى المرسي ما هي معنا، كل شغلها كان معنا اونلاين، وهي حقيقة من العالقين خارج المملكة، لكن يوم سمعتم صوتها كلكم صفقتوا، لأنها ما شاء الله عليها هي كانت صاحبة الفكرة إنه نسويه اونلاين، وهي أغلب المحاضرات أعطتها وهي بعيدة عن المدينة الطبية، لكن كل سنة تكون معنا من الأوائل هنا، فتستاهل التحية حقيقة. دكتور زياد.
الأستاذة وديان المولد. الدكتور أسامة بارشيد. الأستاذة دعاء مهرجي. الأستاذة ولاء فراش. الأستاذة إلهام بوغيس. الأستاذة أسماء المدني.
طيب الآن طبعا حنصل إلى الختام، وهو إعلان المراكز الثلاثة. وكالعادة المراكز التصويت تم إلكترونيا والتحكيم إلكترونيا، وإلى الآن لا أحد يعرف النتائج، فستظهر مباشرة على الشاشة المركز الثالث ثم الثاني ثم الأول. تفضل. ولا أقول لك أوكي عشان بعد كذا يمكن يمشون الناس. طيب قبل النتائج حقيقة سمعتم اسم علوم الدين ظهر في أكثر من سلايد ويشكرونه جميع الطلاب. هو حقيقة السكرتير الموجود عندنا في الخدمات الإدارية في الأبحاث والابتكار، وهذه آخر سنة سيكون معنا وسينتقل إلى مكان آخر، نسأل الله له التوفيق حيثما كان. فحقيقة كانت له جهود جبارة، ولذلك أحببنا نكرمه، وقد ينتقل من عندنا بعد عدة أسابيع أو عدة أشهر لا نعلم، ولكن نحن نحاول أن نحافظ عليه، والله يكتب ما في الخير. تفضل علوم الدين. إعلان نتائج النهائية.
المركز الثالث Prevalence of obesity in hospitalized COVID-19 patients at King Abdullah Medical City, Makkah, Saudi Arabia.
ما شاء الله حاصلين على المجموع زي ما شايفين 90.9، من المحكمين 82.7، ومن الجمهور 8.2. ما شاء الله تبارك الله، ألف مبروك. في العادة نكرم الفريق كامل يكون معنا، بس هذه السنة استثنائية، فطلبنا فقط المتحدث يحضر ويكرم، وباقي الفريق كلهم أونلاين يرون هذا التكريم، وأكيد الآن مبسوطين بهذا الفوز. نسأل الله لهم التوفيق.
المركز الثاني The impact of COVID-19 in hospital prognosis among cardiac patients in KMC.
ما شاء الله، ألف مبروك. حاصلين على 91، الفرق بسيط جدا. 7.3 من الجمهور، من المحكمين 83.7. ألف مبروك للمركز الثاني. المركز الأول وهو الذروة للفريق، ما شاء الله تبارك الله.
The clinical outcome of COVID-19 patients using different treatment at King Abdullah Medical City retrospective study.
ما شاء الله 95.6، رغم أن الجمهور ما أيدهم أعطاهم 6.3، بس المحكمين كانوا أقوياء وأعطوهم 89.3. ألف مبروك، تفضلوا. مين المنتور تبعكم؟ مين؟ رجاء. ما شاء الله. ما شاء الله. حقيقة ألف مبروك، فرق كبير بينهم وبين المراكز الأخرى، بس الجميع فائز، حتى اللي ما تكرم يعتبر فاز بالعلم والجهود اللي بذلها.
وفي الختام نسأل الله أن يكتب لنا ولكم التوفيق والسداد، وأن يجعل أعمالنا خالصة لوجهه الكريم. دمتم بخير، والسلام عليكم ورحمة الله وبركاته.